Okay. Does anyone have any questions? Any questions about like my personal track to becoming an L&D nurse?
I wanted to know made you so what made you want to get into L&D? What was like that burning passion that kind of drove you to it? I don't know any. I haven't had my L&D rotation, and I have not worked with that population.
Yeah.
So I'm just kind of, I guess, just curious.
Yeah. I my previous degree was in gender studies, so I was just always really interested in women's health and women's reproductive rights, and so I knew going into that like healthcare world, I wanted to work kind of directly with women, and really as a bedside nurse it's hard. I didn't see a different, L&D to me felt like the way that I could kind of tangibly make an impact in women's lives and in women's health. So that was kind of my initial inspiration to becoming an L&D nurse. And then, like any field, once you kind of get into it and get your hands dirty in it, you realize that there's so much more to it too. And so, but probably initially it was just kind of my background in gender studies and really wanting to have kind of a tangible approach to kind of healthcare advocacy.
I I wanted to know about kind of your journey from going through nursing school to like becoming a new grad to like actually getting a job on a unit, since that's what I'm interested in. And I feel the same way. Like I just want to go into like something with women's health, like labor and delivery, and it seems a little daunting to like get into that as a new grad.
Totally. It is very daunting. And I think there's a big, there's a school of thought that as a new nurse, it's kind of best to go into like a more general field, like med surg or an ICU or a place where you can really kind of see the broad scope of health and care for, all types of people. But I just the whole time I was in nursing school knew that that was really like not what I was interested in. I was just interested in working with women and laboring women. And so I didn't do anything kind of specific to get a job. All of your rotations, you sort of treat like their job interviews, whether you're interested in the field or not. So I was lucky enough to have all of my OB, or I was lucky enough to have my OB rotation at University of Colorado on that unit. And then I was lucky enough to also have my immersion there as well. And so I think that really helped get my new grad position on that unit. But that being said, I have plenty of friends that went to nursing school out of state and had no experience with the hospital, had no experience with the unit, did not know people on the unit, and got a job on L&D. So it can absolutely happen. And I think that there's a bit of a misconception sometimes with labor and delivery that it's like so super specialized, and if you become an L&D nurse, it's really hard to transition to another field of nursing. And I don't necessarily believe that, especially at a big hospital like the U. A lot of what we do is very med surgy. We have a whole wing of the unit that is just taking care of pregnant patients, and their pregnancies are complicated from a host of factors. So we're giving lots of blood pressure medications for patients that have chronic hypertension or preeclampsia. We're administering lots of seizure medications if they have some sort of epileptic syndrome. We have patients there that are undergoing dialysis. So we're like kind of coordinating dialysis with dialysis and managing their pregnancy. So we do get kind of a lot of that med surg experience on our floor. Labor and delivery is also a bit like an emergency room, because you can't predict when people are coming in. And so we have we call it the obstetric ED. We have our own little emergency room within the unit. And so you kind of gain those emergency room skills of like very quick assessment, triaging patients, quickly getting their H&P and figuring out why they're here. So we get a little bit of that ER, like quick assessment experience. We're also OR nurses because some deliveries result in C-sections. So we also know how to move around an operating room. We know how to scrub, we know how to circulate. And then we are PACU nurses because then we take those patients and we recover them in the PACU. So it's a much more dynamic field. And then of course we're labor and delivery nurses. But it's a much more kind of dynamic field, I think, than it often seems like. I know working with students, they kind of come in thinking like, oh, someone just sort of comes in, has a baby, and like our job is just, to hold the baby and chart a little bit. And depending on those of you that were at the U and how busy the unit is, I'm sure you probably had a very different experience than that. We have lots of emergencies, lots of blood loss, lots of, unpredictable events that happen. So that was like a very long way of answering. You can absolutely be a labor and delivery nurse as a new grad. My recommendation, if it is something that you're actually interested in, is kind of when you write your immersion essay, really kind of speak to that interest and why you're so interested in that. If you have time to become an ACP, the fourth floor and the fifth floor, which is postpartum, do train ACPs. So that's kind of one way, if you don't get your placements where you want, that you can kind of gain some additional experience. But also your first job as a new nurse isn't the be all end all. I have plenty of friends that were ED nurses, ICU nurses, med-surg nurses, and they did that for a couple of years and then transitioned to become an L&D nurse. So it's also, if that plan doesn't pan out for you, your hope of being an L&D nurse is like still there. And all of the experience that you gain from a different job is only going to help you be a more successful labor and delivery nurse. So that's a great question because it is very intimidating.
Thank you.
Heidi, did you have a question?
Oh, can you hear me?
Yeah.
So for those who haven't taken the LD class and they have hard times like interacting with kids, what are some advice you would give us for those who aren't interested but want to be able to be efficient during that time?
Yeah, I mean, really, it's no different than any other rotation that you have. What's really nice is you typically have at least a week or two of your L&D class before you start your rotation. And regardless of who your teacher is, all of the students that I've had, and they've had multiple teachers, they all do a really tremendous job of like giving you a strong foundation. Because it is a field where you do want to know like a tiny bit of background before going into it, kind of understanding fetal monitoring, because that's such a different thing than you've had previously, understanding the different medications that we give, because they're very different than other units. So, my recommendation is just to put in some effort. You guys have, especially if, I think it's for every rotation, or every OB rotation, I can only speak to the one at the U, but you have a pretty sizable preparation packet that your teachers have you do before going to your clinicals. So it's in lieu of like a care plan. You do this kind of preparation packet, and that really helps you kind of prepare for the rotation. So you show up knowing a little bit about what to expect. But then just like any rotation, as long as you show up and you're professional and really engaged and ask great questions, like you will be successful whether or not this is a an area of interest or not. And my recommendation is just to keep an open mind, because while labor and delivery may not be that interesting to you, like I was talking about previously, because it's such a dynamic field, like you will have opportunities to place Foleys, do lab draws, place IVs, practice your assessment skills, all of those things that are going to help you, in your future practice, regardless of the field you're in. Did that kind of answer your question? Oh, I see your comment. Okay, great. What about those of you who have had your OB rotation? Do you want to share kind of how it was different, worse, better, unexpected?
I had mine already. And I did kind of have a question for you. I was at St. Joe's for mine, so I think I had a very different experience than it sounds like you have at UCH. I also, like you, I'm like super passionate about reproductive rights and definitely know I want to work with like female and reproductive rights for my career. I work at Planned Parenthood right now, actually. And so I'm just curious, like, I'm really passionate about abortion care. And I'm wondering like kind of how, like what experience you get with that, or like kind of what the attitude towards that is like on your L&D floor. Because obviously at St. Joe's, it was very like, you couldn't talk about that. Like they don't even do birth control there whatsoever. And I was like, to me, that seems unethical. So I don't know, that experience kind of almost turned me, like, even though I really would like to, like almost turned me off to L&D, feeling like maybe that's not the right place for me. But now your experience is sounding great. So
yeah, that's a complicated question. And you're right. St. Joe's, I can't remember what the hospital affiliate is, but it is, I think it has Catholic origins.
I think it's the SCL one, maybe.
Yeah, I think you're right. And so yes, they do take a stance on not providing abortions and not providing birth control. And so that's a great thing to know about before you apply for jobs, if there are certain, things, because if that is something that you're really passionate about, that it would be very frustrating to work in a space like that you felt like wasn't truly giving the full scope of support when it comes to like women's health and our reproductive rights. At university, we do offer abortions. So it's different because it's a public hospital, and we have a whole kind of family planning clinic that primarily does it. So and this is the minutia is like very complicated, so I won't go into it, because as with anything with women's health and particularly with reproductive rights, there's like so many hoops to jump through, and insurance, whether it covers it, whether it doesn't cover it. So I'll just kind of speak to what we see as inpatient nurses. So when women come to us, and let me see how I'm trying to say this. It's typically presented to us in a scenario that either there are fetal anomalies that really aren't compatible with life, and it's typically kind of pre-viability, so right at 24 weeks or below, something something congenitally has happened with the fetus and it's not going to be compatible with life. So women and families will choose to abort that pregnancy. So we see them in that scenario. We see them in a scenario where, for a multitude of reasons, maternal well-being like can't facilitate that pregnancy. Continuing to be pregnant would be unsafe for the mom. And so we see that in that case. Trying to think when else we see it.
Do you ever see it just like elective, like a woman just didn't want to be pregnant?
No, for those cases, they go to our family planning clinic, and it's all kind of done in an outpatient setting. We only see them if it's going to require kind of more complication, there's like more risk associated with
and like
it.
towards that 24, like second
Yep,
trimester.
exactly. We see it in much later gestations as patient transports. So if a patient had opted for like a late term abortion, and Boulder, Colorado has one of the only late term abortion clinics. And typically all of that is done at that clinic. But in some instances where for whatever reason, the procedure caused like a complication with the mom, they get transported to our hospital and we assist in kind of the delivery of that. The fetus is already passed, but we help with the delivery of that. So it gets very complicated, but it's not like Planned Parenthood or our family planning clinic where you can show up at 6 weeks pregnant, 8 weeks pregnant, and make that choice. It's more of a setting of like fetal anomalies or maternal complications that we see that. Oh, go ahead.
I just like wondering about kind of like the culture and kind of like most providers on the floor's attitude. Do you feel like they're all pretty open to like the fact that abortion is healthcare and, you know, a viable option for women that don't want to continue pregnancy? Or do you feel like it's most like only in those situations that people are okay with it?
Yeah, and I'm speaking, you know, anecdotally, but I would say the vast majority is in support of that decision. I think ACOG, the American College of Gynecology, Obstetrics and Gynecology, has made like a public statement about their stance on reproductive rights. The Colorado Nurses Association, I think, has also kind of made a public declaration of their, you know, opinion on it. So no, I'm sure person to person, of course, it's going to vary. But I generally, it's not a culture of, I don't feel like it's a culture of kind of tiptoeing around those issues.
Okay, thanks so much for sharing your experience. And I totally get that that's just, you know, from your perspective. I just got a very different perspective during my rotation of just, it was like definitely not talked about. And I, you know, I love watching C-sections. I love helping with deliveries, but I just was like, I couldn't work here. Like St. Joe's is a beautiful hospital. That unit is so nice, but I was like, I wouldn't fit in with the culture and like these nurses here. And then even with my L&D or OB class, I felt really disappointed that like they didn't really talk about abortion at all in the class. So
yeah, no, thank you for sharing that. And it is, you know, regardless of what the issue is, understanding kind of like the culture of your hospital and the culture of your unit is a really important piece of it, because you know, how does that not intersect with kind of how you feel in your job, how you feel like you can express your patient care. So it is a really important thing to kind of be thinking about, be observing when you're on units.
thank you.
Yeah. How about anyone else who's had their OB rotation?
I'm in mine right now. So I've had 2 days. And I did one mom and baby and one L&D. And my L&D day was just a little lackluster for me.
Oh no.
We had two moms. One of them was discharged because she just wasn't ready. And then the other mom didn't really, we got her on epidural and Pitocin right as I was leaving for the day. So it was more comfort care for her. And I just seemed to every time miss something happening.
Oh no.
Like, go ahead and go to my preceptor was like, go to the door for this one. There's a birth going on. And I'd like reach for the door and I hear, welcome baby. And I was like, oh, I'm just not going to go.
Cute.
So it was just timing for me. But my person who was with me had a great day. She got to see Momo twins get born via C-section and got to see live birth. I did get to see a circumcision, which was a little difficult to watch, but but the
Yeah.
LED day was really cool because I got to watch the fetal heart monitor strips a lot and take some time with those.
Oh, that's great. It is, for those of you who haven't had your clinicals yet, just kind of hang tight, because that labor and delivery is very much like that. It's sort of like calm, calm, calm. And then, the labor bus rolls in and all of these patients come in. And so it is so hard, sometimes you can catch a unit on, and are you at the U? Yeah. So we have been like so busy, our managers have been staffing. And so this past week, we've had this like small reprieve. But I think there was one day this week, it may have been one of the days you were there. We had no one all day. And then right at change of shift, we had 7 people show up in triage, and they had like a wild night that night. So it's always like, don't despair if you walk in. It sounds like your day was fairly quiet most of the day, but if you have more days, don't despair. If you show up and it's quiet most of the time, the energy of the floor changes pretty rapidly. But it is still, even if you don't get to see a delivery, that practice with the fetal monitoring is so helpful. And just kind of seeing with any of these rotations, the best part is just kind of getting to watch how nurses are nurses, and kind of pick apart kind of the things that you see that they do that you really want to emulate. And also pick apart the things that you're like, you know what, when I'm a nurse, I'm not going to do that. And that is kind of just as valuable as like getting to see all of these things, because whether you recognize it or not, you are slowly starting to cultivate your own nursing practice. And those experiences, really help. But I'm hoping, are you done with your rotation?
No, I've got overnights next week. I've got a NICU and an L&D, and my clinical scholar was like, don't worry. She's like, an overnight will be a busy, fun shift for you.
Yeah, it is typically pretty consistently busy overnight. So I will hope for many deliveries in your future, because it is a very special, it is a really special thing to get to watch. It is something that, like, despite having done it for a while, you don't outgrow, you don't get tired of the feeling of like watching a baby come out, because it just doesn't totally make sense still, and you're still like, oh my God, there's a head and arms and eyes, and it is truly amazing. And yeah, it's amazing to kind of get to sit in that all day and kind of revere what the female body can do, and kind of be in a place to celebrate that, and celebrate that person being able to do that thing, is pretty amazing. So thank you for sharing your experience. And I think I know you from something.
We
the
worked at
Dawn clinic.
Yeah.
Oh my gosh, that's right. Oh, the overwhelming Dawn clinic. Let's see. Does anyone else have questions or OB things about OB that don't make sense, content that doesn't make sense?
Hi, Maddie. I just had a question about like code whites in the ICU, and like what does that look like for ICU care? Because my unit does get them a lot. Like
Yeah.
we're always having to look at protocols on like how often do we do fundal checks, and like is there any guidelines on like fluid resuscitation for them? Should we be doing them to pre-pregnancy levels, or should we be doing them to pregnancy levels? So I didn't know if you had any information on that.
Yeah, no, it's a great question. And there is some talk about L&D nurses on the 4th floor getting cross-trained to the ICU for that reason, because if those of you that don't know, a code white is the code that we call when we're having a massive hemorrhage. So it just alerts interventional radiology, the blood bank, anesthesia, all our OBs, that we're in a situation that we need lots of extra hands and could escalate very quickly. And so depending on the code white, or depending on how much blood is lost during a code white, sometimes the safest thing is to intubate these patients. And we send them up to the ICU because we don't have the capacity or training to care for patients that that are hemodynamically unstable. So often they will go up to the ICU. So I don't know, like the specific protocols once they get up there, because basically we will, if it's my patient, I follow her up to the ICU, but then I no longer become her primary nurse. So typically how we divide the tasks are, I will go up there and do all of the OB related things. And then if you are the ICU nurse, you are doing all of the just ICU piece of it, stabilizing her blood pressure, et cetera. Because at that point, she's not pregnant anymore. So really there's not, for all intents and purposes, treat them like a non-pregnant person. But there are, I'm sure there are some specificities in terms of like, what am I trying to say? Like fluid replacement, because they are having you have crazy fluid shifts anyway when you deliver a baby. And so you don't want to fluid overload them, because if you fluid overload them and their body doesn't know what to do with it, like you third space, it goes into your lungs and then you have a totally different issue. So that's a great question. I will try and follow up if there are specific protocols, but typically the like obstetric piece of it, we try to have you all not take care of, and we just take care of that piece. But yeah, they're scary. They are very scary scenarios, and it is something, a lot of people think, what can go wrong? Everybody has a baby, but truly, unfortunately, lots of things can go wrong. And so a big part of any nurse's job is kind of anticipating what's coming next, but especially in L&D, you're kind of running through every possible scenario of how this delivery could go, and making sure you have everything prepared. But sometimes it's hard, because sometimes it's we had a lady who was delivering with one of our midwife practices, and midwives have a really strict parameters for what sort of patients they will take. They can only be healthy term, really uncomplicated pregnancies. And so there was a patient who was delivering with one of those practices. So totally healthy pregnancy. She was opting for a water birth. She was almost at 10 centimeters, ready to go. She had been drinking, I guess, a lot of water throughout the day, but no one was really keeping track of it. Anyway, before she even started pushing, she had a major seizure, and all of this brain swelling. And they found out that the seizure was due to hyponatremia. So somehow she had, and you may have cared for this patient, but somehow she had totally fluid overloaded herself to where her electrolytes got off balance, and she didn't have as much sodium as her body needed, and she had a seizure. Like, how does that doesn't make any sense, and so we see lots of kind of wild things like that, where you're like, how is this, this shouldn't have happened, and she was fine and her baby was fine, but it's just an example of kind of a strange obstetric emergency that you don't think of when you think of healthy patient, healthy fetus.
On my rotation, I had a patient with an amniotic fluid embolism.
During your rotation?
Yeah. And like our professor even was like, I've only seen like 2 or 3 of those in my entire career. It was crazy.
Wow.
She did survive though. Like, yeah, she did. They said it was like maybe like a mild one. I don't know if it's something that's really like a
I don't think that's
spectrum type of thing. I know, but yeah, no, I was like in a C-section, and then they called like crash C or whatever they call it, and so we go like running to the other OR, and when she came in, I swear I thought she was no longer with us. Like she was so pale and like didn't look good at all. And like I'm like, turning on the warmer for the baby, and like I turn around, the baby's already out. Like it was so fast that they got the baby out. And then like she actually was fine for a little bit, and like was like talking and like holding her baby, and then started like hemorrhaging a ton. So it was kind of a very odd situation, but like you said, like just a really crazy OB emergency that no one really expected. And I guess they're also really hard to diagnose, so it was kind of like suspected, but they didn't know for sure. And
yeah, that's a wild. I have like, knock on wood, never seen that, but the survival rates of those are very low. For those of you guys that don't, it's kind of an the pathophysiology of it is still like not totally understood. They think it's somehow when your water breaks, like kind of an embolism of like, I don't know, fetal tissue, fetal amniotic fluid circulates and basically causes kind of immediate DIC. And so patients just bleed out, and most of the time they don't survive. And it's nothing that it's just like this random incident. There's nothing that leads up to it that makes you think it's going to happen. But they're very, very scary. We've had a couple on our unit. I've never been there, but it's one where you are literally like throwing the patient around, throwing her on the operating room. In less than 2 minutes, you get the baby out. You have the crash cart there. I mean, it's a true obstetric emergency. So that is really wild. Really wild that you got to see that, but also great experience. We don't want, just again, like labor and delivery is kind of thought of as this sort of sweet field, and really like a lot of crazy things can happen very quickly on these units. So that's a really wild story.
Kaylee, Brittany, do you guys have any questions, comments, anything like that?
Oops. Hi. How often are you delivering babies?
Like personally?
Yeah.
At the U, very rarely, because it's just like a 24-hour operation, and we always have doctors there. And so I think I've caught maybe just the head one time, but usually like someone is there within seconds. I did for 2 years work at a community hospital up in Longmont. And there we call them deck docs. We didn't have doctors there 24 hours a day. So it was up to us to call when someone came into labor and say, this person's in labor, this is how dilated they are. Like, I think you should come in or not come in. And at that hospital, I caught many babies, just because, if a baby's gonna come, the baby's gonna come. They're not gonna wait for the doctor. So our doctors were really good at sometimes when they were there, letting us catch the baby with some supervision, just so we kind of knew what to do, because the likelihood of us doing it was high. But at a big hospital with doctors that are 24 hours a day, it's not a regular occurrence. It is quite an adrenaline rush, though, to catch a baby.
And a follow-up, how often on your shifts are you in a birth, in the room during a birth? Would that be every shift, a few times a shift, every couple shifts?
Yeah, it really depends on the census of the unit. So, and I can only speak to this unit, but because we have a lot of different areas, depending on your assignment for the day, you could be a labor nurse, you could be the ED nurse, or you could be, we call it the antepartum nurses, the ones that take care of the patients we're trying to keep pregnant. And so a lot of us have our preferences. I'd say like the days I work, I'm usually a labor nurse, just because that's what I prefer doing. So, in the last 6 weeks, I think I've been a labor nurse for all of my shifts. I haven't had a baby all of those shifts, But there are days where I've had 3 babies in one shift, where it's sort of like, I have a baby in the morning, recover that patient, bring them up to postpartum, get a new patient, she has a baby, bring them up to postpartum, and then I get a third. But that's like a very busy day. So I don't know if that answers your question. It just kind of depends on the day, who's on
Yeah.
the board.
Yeah, just curious, some kind of, rough idea.
Yeah.
And then when you're usually working, would you just be assigned to one patient if you have a patient who's laboring, or would you have 4 patients?
Yeah, that's a great question. Typically it's 1-to-1. But if you have a patient, like Jesse, it sounded like your nurse you were with had 2 labor patients. If both of your patients are kind of in early labor and they're not on Pitocin, we're not augmenting their labor for any reason, you can have 2 labor patients. But the minute one gets an epidural, needs to be put on Pitocin, anything that makes them slightly higher risk, we try, as long as we have staffing, to separate them, and it's 1-to-1. When you're on the antepartum side, so caring for people that you're, trying to keep pregnant, you have kind of a normal med-surg, 1 nurse to 4 patients assignment. But labor at max 2, usually 1. And then once they're in active labor, you have to only have 1 patient because you're just kind of in there a lot.
It's great. And then postpartum is a whole different floor. So you're not on that floor. That would be a completely different unit that you would work in.
Yep, exactly. It's up on the 5th floor. So when a patient delivers, we care for them for the first 2 hours, because that's kind of the most acute time, the most likely time that they're going to hemorrhage or there's going to be a complication. So that's when we do those Q15-minute fundal checks and all of those things you guys are learning about in class. And then as long as they're stable, after those 2 hours, we bring them up to the med-surg, or not the med-surg, the mom baby unit. And then that's where they remain for the rest of their stay. Yeah.
So I had a question. Something that I noticed about L&D is that everything is very gray. So there's really not a lot of black and white. This is what we always do. This is what we always do. Because there's never a, this is what we always do situation. Mm-hmm. So for me, that's really difficult. And L&D is on my short list for what I want to do. So how do you kind of get in that brain space of letting things just kind of be what they are, when nursing school is always like, no, it's A, it's B, it's C?
Yeah, totally. It's a very, very, very hard transition. And nursing school, you're right, is very like, there's here are your options. There's only one option. And regardless of what kind of nurse you are, that reality of like actually being a nurse and realizing, well, there are 3 good options. So which one am I supposed to pick? Or more likely, there are 3 bad options. Which one am I supposed to pick? And so it's challenging. I mean, being a new nurse is really challenging. Especially, I think it was challenging for me to be a new nurse on L&D, just because you're learning so many different pieces that make up a labor and delivery nurse. But then, right, you have this whole, like, you want rules. You want, like, I show up and I do 1 through 10, and then I've completed my morning, tasks. So you just kind of get more comfortable being in that uncomfortable mind space, which is like not a great answer and probably not the answer you want. But it does get easier. But also, you're not a nurse in like a silo. You have all of these coworkers. And I don't know if you witnessed it, but it's a very collaborative unit for that reason. Because those of you that have experience interpreting fetal monitors, and those of you who don't, you will, but that is also another gray piece of our job, where you're kind of interpreting this strip, but 2 people can be looking at the same strip and call it 2 very different things. And so to navigate that, you just ask lots of questions. You just ask, like, here's the situation, what do I do? And the other nice thing about working at a big university hospital is that we have residents who are also learning. So it's a very kind of teamwork, collaborative environment where if I'm not sure, I feel weird about what we're doing, like I just call the resident who's a couple doors down and talk to them about it. So it's, it's still uncomfortable, but you kind of get used to knowing how you're supposed to navigate it, I guess, when you are feeling uncomfortable. But it's a super tough transition. And it just comes with time. But especially, if you're part of a new grad program, they get that. They know that that's like one of the biggest hurdles people have going from nursing school to being a practicing nurse. And so I think at least at the U, I think they really help kind of, coddle you a little bit and like let you know that you have all of this support, because it is so scary. But yeah, I would just say keep asking questions and acknowledging when you don't know what to do, when you don't know what to do next, just being really honest. I still will like get in situations and like have to ask the charge nurse, like, I have no idea what I'm supposed to do right now. So you definitely don't outgrow that feeling. You just have it a little less often or just get a little more comfortable with it. But it's a transition for sure. Oh, I think you're muted.
Thank you. Thank you for saying all that. I was with Courtney. I don't know if you know her, but she's only been a nurse for a year now. She's a pandemic graduate like we will be. And so she was really comforting about that stuff too. But it was really cool to watch the fetal heart monitor and she'd go, oh, she's probably either vomiting or moving right now. And like, just to be able to get in just a year, she's gotten so far that she felt comfortable doing what she does, then that made me feel better.
Totally. I love when students are put with new grads. It's so overwhelming for the new grad, but I think it's so encouraging for you guys because you're not that far away from being new grads, and to see like, oh my gosh, you do become a nurse. You do like figure out how to care for patients and know all the numbers and know all the meds and manage the pumps quickly. It does happen. It's just so hard to see it when it's you, but it does and it will happen. It just takes time.
Mary, did you? Oh, sorry, Jessie. Mary, did you want to ask another question? Did you get a chance?
Oh, I'm okay. Thank you.
Okay. Then I'd like to ask one. We've got about 8 minutes left.
Yeah.
So hopefully if you have like a happy story to finish this off after this question, I think that would be good. But I'm just curious if you have like a demise, either maternal or fetal, how do you work with that? Because that's one of the aspects of care that I kind of fear.
Yeah. And that, is another area of this job that isn't talked about, as much as it probably should, because it does happen. And it's our job, to care for those patients and those families. And it's kind of the worst part of being an L&D nurse, but it's, it's still our job. And so, caring for those patients is really hard. But it's helpful, at least for me, to, remember that I'm the nurse taking care of them. This is like not my event to be the center of. And so that just sometimes can help get my emotions in check, kind of put, my sadness for them aside. And, because sometimes a challenge of it is that you become so emotionally connected to those patients and those families, and you feel so deeply for them that sometimes it can cloud your clinical judgment because you're thinking about caring for them in a very different way than in like the medical way. If that makes sense. But they're really hard, and it's taken me kind of a long time to feel comfortable, ish being the nurse for those patients, because you sort of can struggle with like, what am I supposed to say? How am I supposed to ask some of these really difficult questions? because you do need to ask questions like, does this baby have a name? Do you want me to call the baby by this name? Do you know the gender? Do you want to know the gender? After delivery, do you want to hold the baby? Do you want to not hold the baby? We have a wonderful perinatal loss coordinator who is a former NICU nurse. And so she comes and really helps nurses facilitate those conversations with patients, because we need to gather that information. We need to be there for support. But we also like have kind of the other medications assessments piece of their care that we also need to do too. And that can't be put to the wayside. So she is a wonderful resource. But it's really hard. And I've kind of felt, or learned through doing, many of these deliveries, the best is just to, begin with honest, like, this is horrible. This is something that nobody is supposed to go through. And I'm so sorry that, this is what's happening to you and your family right now. And just kind of creating a environment in the room of just like, we are here, you get to dictate this ship, you get to tell us like what you need. But it is really challenging. And then it is important, and I think nursing in general could do a better job of this. But then how do you care for yourself after? Because you sort of end those shifts realizing that you like haven't even checked in with how you are feeling. And depending on what's going on, and the scenario of this happening, you may, if you have, it's also important to then spend some time after your shift kind of reflecting on how it made you feel and how you can best care for yourself after something like that, because it does take quite an emotional toll on you. So I don't know if that totally answered. Did you have a specific kind of question about caring for demises?
No, just general thoughts. Thank you.
Yeah, it's a very difficult scenario.
Yeah. So I've got just a few minutes left. Do you have like a really positive, happy, wonderful story to share, something like that can end this on a happier note?
Yeah, no, but I mean, that's a great question, because that is, that is a reality of our job. I mean, and that being said, though, most of the time, like, I come home and all I have are like sweet stories. So, I mean, I feel like there's a million to choose from. One that I love so much is we had a surrogate. So it's a woman who finds like a family that for whatever reason can't conceive or doesn't want to conceive, and she carries the baby like through the full gestation and delivery. And so we had this guy, he was going to be a single dad, and he had this woman who decided to be his surrogate. And they did IVF, and IVF, you have a high chance of twins and multiples. And so this IVF turned into triplets. And so this woman was pregnant with triplets, and it was time for delivery. And I was the nurse during the delivery. And so she was going to have a C-section. With triplets, you have to have a C-section. And the operating room, those of you that have been to the U, like, know the operating room kind of looks big, but it's also not huge. And so we had 3 warmers, like 3 stations of the warmers. This woman, her belly is just enormous with these 3 big babies. And then the father of the baby was in the operating room too. And it was just amazing to kind of see like baby 1 come out, and then baby 2 come out, and then baby 3 come out. It didn't seem possible. But the sweetest thing is, like, a big part of our job during a C-section is to call out birth time and like chart it in the computer. But dad didn't know that we did that. And so I watched him every time one of his babies was born. He had his iPhone and he would take a picture of his watch because he wanted to know the exact time these babies were born, not knowing that we are recording them too. And it was just such a sweet, like, sweet scene of like this massive OR with all these teams and all these babies, and this dad like just elated and like wanting every moment, wanting to know the minute and second each of these babies was born, was a very sweet thing to witness.
That is a wonderful note to end on. Thank you so much, Maddie. We really appreciate it.
Absolutely.
Yeah, I think you brought a tear to a couple of our eyes. So
well, please, I know an hour isn't a long time, and you guys asked some really great questions. Those of you that would prefer to email me with questions, please feel free to. I think Meg has my email. And then those of you who haven't had your OB rotation, I may see you as your clinical scholar and or your preceptor if you're at the U. So I look forward to that, but please don't hesitate to reach out, because I love OB. I love being an L&D nurse, and we're always trying to recruit more people.
Maddie's an awesome preceptor. You guys would love her. So. Okay, I hope that you guys have a wonderful day. Thank you all so much for coming.
Thank you so much.